This is a fantastic subject before lunch, vomiting. Just to prepare you, no? After anorexia, now something more pleasant, I think. And the subject is very particular for what Tiziana has stated and Stefan too. The fact that disorder, psychological disorder, and above all, eating disorder are continuously evolving, are continuously changing. And we realized that there has been a great change when we started our intervention research in 1993 at the Center of Strategic Therapy in Arezzo. As we had done before with phobic obsessive disorder, we carried out a particular type of research, the intervention research. That means we started working with a great number of women, in this case, above all women, with the same type of problems, eating disorder, trying to select and discover the best way to deal with this problem. And through our clinical work with the different type of patient with the same structure of the problem, with the same pathology, we can say, we created the first protocol of treatment for this kind of disorder. That the creation, this type of work allowed us to obtain two main objectives. First of all, we created protocols of treatment, something that seemed to us to be the best way, the most efficacious and efficient way to solve this kind of problem. And but this research allowed us to obtain more information about the modality of persistence of this type of disorder. As Giorgio Nardone used to say, we can know a problem by its solution. That means that only when we have solved the problem, we can be sure which kind of problem it was. And through this particular type of work, we discover that the reality of eating disorder from a diagnostical point of view was quite different from the one that we can find in psychiatric literature. We, in every manual such as DSM, the American one, we find two main eating disorders, anorexia nervosa and bulimia nervosa. In both disorders, we can find particular subtypes, and we can find the subtypes called with purging behaviors. That means subtypes with purging conduct, such as vomit. But there is no another type of disorder. We realized that through our research that we can identify a third type of disorder that we have called vomiting. This disorder is based on eating and vomiting in a compulsive way several times a day during a not so long period of time. This disorder presents different characteristic of persistence, different modality of persistence, and for this reason it needs a different type of intervention. In other words, we can say that the strategy that worked in solving bulimia nervosa without vomiting didn't work when vomit appeared. So we discovered that we need to change our strategy. We needed to change our protocols. We had found another type of disorder. If we consider operative diagnosis, that is a diagnosis, that a diagnostic disorder through their modality of persistence. Vomiting has a particular type of formation. It's not something that's born in a different way from the other one. Usually we have women with anorexic or bulimic tendencies, that means that start binging or start avoiding food, but at a certain moment, we can say by chance, they discover that vomiting is a simpler way than abstinence and binging to keeping on the pleasure of eating and without the need to gain weight. And without creating this effect of alarm in the family. So, at the beginning, vomiting seems to be a good attendant solution, a good way to enjoy food without losing too much weight or gaining too much weight. But when this cycle of binging and vomiting is continuously repeated, it becomes something that can seem to us incredible, but it becomes a really enjoyable pleasure. Something that they like so much they can't renounce to it. And the fact that pleasure is the base of this disorder can be understood if we follow the study of Henri Laborit, the Nobel Prize winner for biology. He discovered that every type of behavior, if even the less pleasant one, if repeated many times, can create an intense sensation of pleasure. So through this repetition of binging and vomiting, these women create a different discovery in their life. The idea is that the relationship with eating and vomiting is a sort of secret lover. We call in this way with them, and majority of them understand very well what is a secret lover. And we describe them this idea that everything starts with a fantasy. No? They start in the supermarket, for example, just imagining when they come back home and binge. And they can describe a sort of excitement during this fantasy. Then there is the phase of the consummation, the phase of the binging. And after that, the phase of the discharge, vomiting. If you analyze this sequence from a processual point of view, it's similar to the sequence of a sexual intercourse. There is a fantasy, there is a consummation, there is a discharge. But I underline that not to intend that there is a sexual correlation, just to show you that this sequence is quite simple to develop pleasure. There is something that I feel in and then I discharge. And so once vomiting has been created, it becomes what we have called an emerging quality, something different from the old matrix that can be bulimia and anorexia. And for that is something that needs different type of intervention. I've put here the distinction that we have done from an operative point of view between bulimia nervosa and vomit syndrome, because in both cases you can hear talking about vomiting, but in the descriptive diagnostic label of bulimia nervosa, we find that vomiting is considered just a symptom of the disorder. The focus of the therapist is usually on the moment of the binging. For example, trying to help the girl to control the moment of the binging. But the fact that there is vomit or not is not so important. And vomit is considered one of the several types of purging behavior. In our diagnosis of vomiting, the idea is that these women, this girl, eat in order to vomit. vomiting is not the way anymore they have choose to free themselves from the excess of food. It's no more an attempted solution not to gain weight. It's the aim of the binging. And when during the first session we talk with these women, and through the dialogue we guide them to discover for a category or describe as in the other two that this is the way they live their syndrome. They plan the moment of the binging and the vomiting. They most of all are aware about the fact that they eat in order to vomit, and that is very, very pleasurable. We use another image, not only the one with the idea of secret lover, the image of a demon. The ritual is a sort of demon that they feel inside and they can't resist. Everything in our language in the first session is about the pleasure-based disorder. And from this point of view, we can say that vomiting is not at all an eating disorder. We can compare it to a sort of compulsion, with the main difference that a compulsion is usually based on a phobia, on a fear. In vomiting, the compulsion is based on pleasure. So from this point of view, we can say that vomiting is a sort of perversion based on food, not just an eating disorder. And we can understand so why it's so resistant to change disorder. Because when we deal with other type of problems, we don't have to guide something to renounce to a pleasure. When we work with pleasure-based disorder, we face a great resistance to change in our passion. And another discovery that we have done is that there are different types of vomitors, we can say. That means that we need a different variant in our protocols of treatment to unblock the disorder. That means that this kind of a disorder are more complex than other one. So we need a different type of variant. And I'm going to show you the 3 different unblocking maneuver. I talk about unblocking maneuver because we don't have enough time to treat all the treatment, the 4 stages treatment, the entire protocol. But I think that can be really interesting to see how we can unblock this disorder according to its modality of persistence in these 3 different categories. So just not confuse the unblocking maneuver with the whole intervention. The first category is the category which is ironically called unconscious transgressive vomiters. The idea of transgressive is related to the idea of pleasure. But in this case, we have normally young women, that can be teenagers too, who are not aware of the pleasure-based of their disorder. They haven't realized that it's a sort of perversion. And they are usually very, very blocked girls with a very strong sense of morality, and I have to say that this is a category that is decreasing now according to the evolution in society, but it was biggest at the end of in 2000. But we can find some of these girls actually at the moment. This is the simplest category to treat because it is all the therapist needs is to be able in reframing the situation. During the first session, we start after a few questions about the sensation the girl lives, the way she arrange this ritual, no? This ritual with these three phases, and we start asking questions that are aimed to guide her to discover by her own experience that this is a pleasure-based disorder. So we can ask her, what do you feel exactly when you start thinking about the idea of eating? What are your sensations? Trying to guide her to discover the fantasy, the consummation, and the discharge phase. When we have obtained the girl to describe us the way she lives, the ritual, so we can ask her which kind of other human activity this ritual reminds to you. Do you catch any analogies to something different, this fantasy and then the need to consume and then the discharge, freedom discharge? And when they realized that there is this strong analogy from a metaphorical point of view with a sexual intercourse, they feel really shocked. This is a very, very strong corrective emotional experience that create a bad sensation toward the ritual. So with this provocative reframing, we start to guide the girl to think that every time that she does a ritual is such as she was doing something different. And if the therapist is able to do that in a very subtle way, making the girl think the most important things, this is enough to put the strong morality of this girl against their symptom. And they usually break up the symptom between the first and the second session. They can't imagine themselves doing something so perverse. That is, using the idea that they are very blocked and they have not realized the pleasure of the ritual. But it's not the main category we face at the moment. We can say that the 50% of vomiters are in this second category, what we have called conscious but repentant transgressive vomiters. These are women who have realized that their symptoms are a perversion based on pleasure. They know that this is a sort of demon. They can describe every phase. They can describe the idea of the secret lover and very well. But they have realized that the secret lover is taking too large space in their life. That is not so useful at the moment. They would like to stop, but they can't do it. They are not able. So this is a category that can have a long-term story of vomiting, but in which the women are really willing to collaborate with the therapist. They know that it's a pleasure, but they know that this pleasure is spoiling their life from other type of pleasure. And it's important to stress out that, for example, while a vomiting syndrome is present, it's really, really rare that the person can live in a satisfactory way his or her sexual life. Is as the erotization was moved from the current way, sexual way, to the way of the ritual of vomiting. So these are a category in which the women know that they are renouncing another type of pleasure. and they want to stop. So we can use our fundamental unblocking maneuver that now we usually use at the end of the first session without waiting too much. We want to put this person in a situation in which she has to demonstrate us that she wants to change. And we ask her to follow what we have called the interval technique. We know that even when the girl wants to stop, she usually tries to control the moment of the binging. But the more she tries to control the binging, the more she loses control, the more she eats. So we tell her, okay, we know that at the moment we are not able to stop doing that. And if you try to control your binging, you just make your binging more powerful. So if you feel the need to binge and vomiting, do it. You can eat whatever you want. Just follow this indication. When you have eaten everything that you want, and you are at the moment that is the right moment for you to go and vomit everything, just stop. Take an alarm clock and put it to go out after 1 hour. And during this hour, you have to avoid eating or drinking anything. When the alarm clock goes off, you have to go and vomit everything. So, what happens if the girl follows this indication? That we are interrupting the ritual. So we are spoiling the ritual of its pleasure. To give you a fun example, it is like if during a sexual intercourse, just a moment before the orgasm, something stop you, and someone stop you and tells you, okay, now stop, and you can go on after an hour. The effect is the same. The pleasure of the ritual is the pleasure of the whole ritual. If you stop the ritual at this moment, it's not more pleasurable. And the girl discovers from the first moment that this indication spoils the ritual. But if she is in this second category, she follows the indication. So we increase the interval 2 hours, 3 hours, till 3 hours and a half. And doing that, we don't, we interrupt the pleasure at first, but we obtain another effect, that we transform a pleasure into a torture. Because when I am very full of food and I feel the desire to empty myself in this very moment, if I have to wait 1 hour with this terrible, teasing, irritating sensation of fullness, this hour will be a very, very great torture to me. And at the same time, the girl starts with the fear to gain weight, because she knows that she has to maintain all the food during an hour. So as a fact, we obtain that she discovers again her capability to control the quantity of the binging. The more we create a bigger interval, the more she learns in a spontaneous way to diminish the quantity of food. So at the end, she will be able to have a normal meals, not to binge anymore, as the effect of this increasing period of time that we ask her to put between binging and vomiting. We have this maneuver follows the ancient Chinese stratagem, let the enemy into the attic and move the ladder, because we take the pleasure and we transform it in a torture. But this seems to be too simple, because we know, I think that everybody will know that there is a third terrible category. That is the one we have called conscious completion transgressive vomiters. That means women, they are fully aware of the character of poor pleasure of their syndrome, but they have no intention of giving up their secret lover. They don't want to renounce to pleasure. So why they come to us, you are asking? Oh, two main reasons. The first one is someone else compelled them to come to therapy. If they are young, for example, or just to not to fight with the husband. So someone else bring them to therapy. Or the second possibility is the most terrible one. These women are so transgressive. They like to eat and vomit therapists too. They have fun in that. It's a sort of challenge for them. Now they write and see us with this attitude, okay, I have seen so many therapies, show me what can you do, with this very strong transgressive attitude. So this is the most difficult category to deal with because either they tell us, I'm here for that, but I don't want to stop that, so change me without changing me. Or they discover that when at the end of the session we ask them to follow the interval technique and they stop us and tell us, I'm not going to follow that. I know that if I follow that, you will spoil everything. I don't want to do that. So we can discover this category during the session or between the first and the second session if the person come back and tell us, I haven't followed your prescription, I didn't like it, I don't want to renounce to my pleasure. So we have to adapt our intervention to their perception. The main idea of our way of working, the idea of constructing protocols, variant of protocols, is adapting treatment to patient and the idea of the patient has to fit our treatment. So we created another way to deal with pleasure. That is the idea to follow the language of the patient. These are very transgressive persons, very transgressive women. They just think about something pleasure. So we can guide the patient to increase her pleasure by constructing the perfect binge. That means that during the first session, if we realize that there is this attitude, we start in a provocative way to the patient, asking her, okay, but are you sure you're such a good transgressive? Because, you know, it seems that you choose the food you find at home, you not arrange the perfect place to do it, you don't cure everything in details. Don't you think that it could exist a best way to do that? And another aspect, if you do that ritual, if you meet your secret lover twice, 3 times a day, 4 times a day, it can be so nice, no? You know that delaying increases pleasure. So I propose you something to help you to be a best transgressive person. You should do it just once a day, but enjoy it at the best. You should choose the right moment to do that. Maybe you could do that during the night. That is the hour of witches, you know. Now you could put candles and prepare the table and while you describe that, it's incredible to see the faces of the patient. You are opening them a new world of pleasure. No, they follow you, they love you because you are just talking their own language, the language of transgression, the language of pleasure. So They won't follow the idea of interrupt pleasure, but they follow you very well on the idea of increasing pleasure. And when they follow this prescription and they really discover that doing the ritual once a day is really more pleasant than doing in a hurry, than doing more time, we have obtained two main results. They have saved the pleasure, they have increased pleasure, but they have decreased the quantity of the symptoms. You imagine that we are talking about women whose entire day is used to binge and vomiting. So you obtain to free a lot of time to work on the quality of the binging, decreasing the quantity. And with the idea of the fact that delaying pleasure increases pleasure, we guide this girl to do the ritual once a day, every other day, and so on, but in a very slowly way. This is very important. If they feel that you are going to spoil pleasure, they won't follow you. But when we start to be able to free days from the symptom, we start with the second important part of our work. That is, okay, but you who thinks you are so transgressive, do you think that really the best pleasure in life is eating and vomiting? Are you sure you won't be able to discover other kinds of pleasure? And we start guiding them to recover the relationship pleasure from every point of view, with friends, with men, the pleasure of seduction, for example. Don't forget that we are talking about a sensation-seeking person. They had a great need of strong sensation. So we have to help them to discover sane modality to obtain this strong sensation. So we keep on our intervention delaying the ritual day by day and working on other parts of aspects of their life, relationship with men, seduction, if it is need sexual, according to their situation. And so we can reach a moment in which this girl have just one binge a week. And we have to maintain that till they will be able to tell us, okay, it's enough. This is the category in which we don't have to be to go too fast, because if you go fast, we go out of the road. And this is another Chinese stratagem, that's filling the sea unknown to the sky, because we are follow their steps, the idea of increasing pleasure, but at the end we make them able to renounce to that pleasure to choose other type of pleasure. Our treatment protocol, you know that we construct protocol and every year we measure our efficacy and efficiency, because we are really interested not only in the fact that our work works, but even in the idea that it has to be rapid, fast work. This is not the efficacy at the moment. I think is a little bit increased. It was the one at the beginning of the 2000. We have an efficacy of 82% with an efficiency inferior to 15 sessions. All the category together. And I put our bibliography that is Prison of Food. I was telling Stefan this morning that it has been translated to German too, but and it's a very, very strange for us. They forgot to put our name. So there is just Giorgio Nardone name, and it's really funny because this book has been translated to lots of languages, in French, in Spanish, in Russian, and just German, no? I've forgotten. That is quite funny. So just to say that you can find the book with Giorgio's name. I don't know the name in German. I don't know if it's Prison of Food translated into, but it seems to me something different, not the literary translation. So I would like to end my presentation stressing one more the idea that if disorder evolved, protocols treatment have to evolve, that we have to change in accordance to our disorder, and that this is a statement from Nietzsche, is a true statement not only for disorder but for therapies too. Everything that is absolute, even treatments, belongs to pathology. Thank you.
Italians have a strange kind of humor. I don't think that's funny that they forgot your name.
I'm very able in reframing, in positive reframing.
I was a reframing.
I've discovered it 3 years ago. At the moment, I didn't find so funny too. Don't worry.
I think it's important to remind everybody that the three different interventions are really targeting towards the different kinds of resistance depending on the position of the client, and that this is not an example for the whole treatment protocol and the method, which I think is important to know.
Yes.
So it's a really good example of how to fit the intervention in the early stage of therapy depending on the position of the client.
Yes. This is the unblocking maneuver. Then we need 2 more stages of our therapy to follow the person and to create a new balance. And it would happen that during the 3rd stage of our treatment, we have to guide the person to discover how to eat, no, after the problem of vomiting is solved. So it was just to stress that, unblocking maneuver, to unblock.
In the 1st stage, which is absolutely necessary. Any questions to Roberta? Sonia has a question.
It doesn't work. It may be. Okay. Okay. Oh, we start trying the best. That is, every time that you binge, at the end of the binging, you have to stop and wait 1 hour, and then you can go and vomit. If the person is able to do that, we have unblocked, because they will stop to do that 7, 10 times a day. It's a torture to wait too much. But if we discover, for example, that the person is able to follow the indication, but not at all, we can create a mixture between the 2 main prescriptions. For example, so we have discovered that you need once a day without the interval. I can give you this possibility just once, do it at best, but for the other one we have to wait. So we have talked about pure categories, but we have to adapt our intervention to our single patient. So if a person is able to follow the first indication but not at all, we can create a different type of request according to her answer.
But I imagine that if you experience some events in the day, they are like a torture, and you have other experiences where it's not like a torture, but it's the pleasure that you're seeking. Isn't that very ambivalent and creating more problems than before? Because then I really have the I can see that there are times when I have the torture and there are times when I have the pleasure. So what would bring me to choose?
Okay, I understood.
To choose the right thing.
Okay, we are talking about a category of people that are really who have realized that this pleasure is spoiling their life. So they know that it's a pleasure, but they know that it's a pleasure they don't want to feel anymore. They are ambivalent. So we are helping them to discover if they are able to renounce to it from the very beginning. If they are not, we can adapt our intervention. But the resistance of change is the idea that I want to stop it because I want to discover other type of pleasure in my life. No? So there is a different position of our client. If it's not, we don't have this particular category, we have to deal with the third one. So we can say that we discover which category we are treating after we ask the interval technique, no? Because we usually try to start with this technique because it's the faster we have. But if in the second session the person come back and tell us, okay, no, I can choose torture, I want to choose pleasure, we have to change the strategies. It's an intervention research, the therapy too. We discover how we can unblock the person through our intervention.
Some of the clients I had in mind, I think their solution or variation of the homework task would be that they decide not to binge to avoid the torture.
Yes, this is the most important effect. I don't want to do that. Yeah. So I don't want to feel this bad sensation, so I renounce to binge. Everybody is in the fantasy of binging now. No, it's the fantasy phase and
fantasy of pleasure of all sorts.
You said that eating and this pattern this women have is most like the sexual pattern, but they have it on they conscripted it on eating. But did they make that change, or is eating because the sexual part is not available for them?
This is a very frequent question, no? And this is the question which led us to the search for the causes. What I can say is that we find a strong correlation between the presence of vomiting syndrome and the absence of a strong pleasure in sexuality. But it's not, we are not interested in knowing if the person developed a syndrome because of her sexual life was not so satisfactory, or is the syndrome that creates this type of problem. Now there is a correlation, and I think that the effect is physiological. No, there is epidermic sensation moved from the sexual part to this part. And so, from this point of view, I think that we can say that every one of us, if starting this kind of syndrome, won't be able in the future to live in the same way his or her sexual life. But it could be that a woman discover that binging and eating is so pleasant, having a not satisfactory sexual life. But I want to do a causation. I think it could be danger, no, to choose an initial cause to explain the syndrome. What we have discovered is that the syndrome arises by chance. I thought, oh, maybe I can vomit something, so I'm not going to put weight, and then everything starts.
But I think what Michaela maybe also has experienced is that as an explanation for clients, sometimes it's helpful when you find out that there's one of the reasons that could be is that with an experience of rape or incest or sexual abuse or other unsatisfactory experiences in sex, that it's like normalizing the problem, but that you've moved something to a different area of pleasure, because in sex it's a problem, and then the goal becomes to maybe like reshift. Which is also from, I remember your work, that you then find out, okay, what are other areas of pleasure, and what might be the cause is that there's a restraint in that area.
Okay, this is what we eventually can discover after the unblocking. No, right. Your example, it could happen that after the unblocking of the syndrome, we discover that the girl had lived a trauma, sexual abuse, for example, in the past. And that means that now we have to work on this problem too. But we usually start from the symptom that we can see and that the person is complaining about. No? Just not to put our ideas in the patient. So, is it true it can happen that you discover that there was this kind of problem, but we discover it afterwards, after the unblocking, and then we have to do to work about that.
Martin, do you still, after the unblocking, do you still tell them about the techniques and about the strategies? Do you tell the clients?
If we explain that?
Explain the techniques afterwards?
Okay. It's not needed, because when, for example, with the interval technique, when the person comes back, she usually tells me, oh, you have spoiled everything. I imagine that it was so terrible. She has already discovered. No, and so I can tell her, yes, is it true? I have to spoil your ritual if you want to be free from that. No, so yes, it's very, very important. But they discover it. They discover it. It's not so difficult to discover that it is no more pleasant. The torture arrives later with the 2 or 3 hours. At the beginning, it's simply not pleasant anymore. Right.
Entschuldigung, ich sage jetzt bewusst in Deutsch. Ich werde es gleich auf Englisch sagen. Also, was ihr hier zeigt in eurer Arbeit, gefällt mir deshalb so sehr, weil es eine funktionelle Diagnostik ist, die ihr anwendet. Nämlich und eure Methoden richten sich nach dem Problem, werden dem Problem zugeschneidert, also zugeschnitten, Entschuldigung, auf das Problem zugeschnitten. Und das ist genau das Gegenteil dessen, was man befürchtet, wenn man über Störungswissen spricht, nämlich Labeling, nicht? Dass wir eine Störung erzeugen und sie nicht lösen können. So, what I was talking about is that the functional diagnostical way you've just shown us is a beautiful example to see how you tailor your interventions to the problem. And this is the very opposite of labeling. So people shouldn't be afraid of thinking about pathologies, and not only in a solution-oriented or narrative way, because this is, yes, it's not labeling.
No. It's just using words to communicate. And I was thinking about the idea of the trauma because with Federica Cagnoni, a colleague of mine, we have just published a book about the post-traumatic stress disorder treatment, no? So about trauma. And what we have discovered is that we can often find one particular disorder that can be an eating disorder or an affective phobic disorder one, unblocking that, and after that discovering a post-traumatic stress disorder, for example. No, so we can, we have to change our work according to which we discover, but we use labels just to communicate, just to communicate what we have to solve, what we have to create differences.
Danke, sehr schön. Noch Fragen? Ansonsten leitet die letzte Präsentation mehr oder weniger über zum jetzt anstehenden Programmpunkt Mittagessen. Mittagessen heißt 14:30 Uhr, bitte möglichst pünktlich, es ist genug Zeit. Wir würden Sie auch ersuchen, nicht alle in das gleiche Lokal zu gehen, sondern sich aufzuteilen. Möglichst pünktlich, bitte herzlichen Dank noch einmal an Roberta Milanese und Tiziana Verbit. Und Mahlzeit.
Bing, bing.